in patients with ovarian endometriosis cyst. Thank you for your introduction. It's my great pleasure to participate in this conference. So today's topic is highly related to fertility preservation. It seems that it has no relevance with HIFU treatment, but I think it's highly relevant to the fertility protection. So how to protect the fertility of the patients with ovarian endometriosis? So my speech will consist of following two parts. First, impairment of the ovarian endometriosis cyst to fertility. Second, a whole process fertility protection in patients with ovarian endometriosis cyst. So I will jump the introduction to the endometriosis cyst. The factors influence the ovarian reserve of the patients with ovarian endometriosis cyst, including the interior factor and exterior factors. For the surgery and recurrent surgery, it will impair the patient. The ovarian endometriosis cyst leads to the dysfunction of the ovarian reserve. The cyst influences the function of the ovary, inducing inflammation and subsequent fibrosis, and impair the overall cortex and the stroma of the follicular of the nest. And the quality and quantity of the follicle will be impaired, inducing the dysfunction of the ovarian reserve. Some research shows that the oxidative stress induces the egg apoptosis and the necrosis of the early follicles, leading to a burnout effect. The pool of the primordial follicle is consumed, and the number of the follicle in the ovarian tissue surrounding the endometriosis cyst is decreasing. And the follow-up pregnancy and delivery of the patient will be transferred to reproduction doctors who have deeper feelings in this aspect. A lot of research and studies shows that the endometriosis will reduce ovarian response to ovarian hyperstimulation. All these studies have proved that. So during the surgery, the ovarian reserve or ovary will be impaired, including impairment to the cortex and also the stroma and the vessel. It will take or exfoliate a lot of healthy cortex, which include a lot of healthy follicle. So extraotomy will also impair the normal tissues in the ovary. Edema and inflammation will be induced after the surgery. Laparoscopic surgery will also influence the ovarian reserve. And we have checked the AMH, and we find that the patients with relatively low AMH and type 1, 1 month and 3 months after the surgery, we find that AMH is decreasing. Recurrent surgeries, with no doubt, will impair the ovarian reserve without appropriate management, leading to the recurrence of the disease without well informing of this condition. It will further impair the patient. The second or secondary surgery will exfoliate more tissues impairing the ovarian reserve. Therefore, repetitive or secondary surgery will aggravate the disease, reduce the quality of life, impairing the psychological and physiological health of the patient. And how to protect our patients in whole procedure. My suggestion is early diagnosis and early treatment, especially for the women of reproductive age. We should try to diagnose the disease, make the maternal plan for treatment, maximize the management of medication, make the surgical timing preciser, and formulate a whole procedure management plan. First, for the patients who have reproductive needs but cannot conceive naturally. Second, for the patients who refuse to receive the surgery. Third, consistent with ART standard and after treatment for patients with ineffective hormone treatment and or poor tolerance to pain. For all these three types of patients, we should establish early diagnosis and early treatment. Classify them into the patients with fertility or not fertility willing. We should reduce the time of the surgery and cooperate with the physician and the reproductive department to provide medications as early as possible. And we should get full informed of the pregnancy plan of these patients, including the information about the endometrium, if the patient has pain or infertility or short-term for pregnancy. We should formulate individualized plan for the patients. As for ovarian endometriosis cyst comorbidity with the infertility, we should consider the timely pregnancy. So the decision should be considered or taken based on individualized needs. As gynecologist, a good operation is conducive to protecting the ovarian function. For the endometriosis, we have HIFU, but for other diseases, we have to take some aggressive or invasive surgeries with full examinations to check whether there is possibilities for infertility or complications, so as to protect the ovarian reserve, reduce the loss of normal ovarian tissues, protect the blood supply, reduce the use of electrotomy, and reduce the impairment of extracoagulation to the ovary. I'd like to show you a video of the treatments on endometriosis.
或是手术视频我自己给你讲，我刚才拿了一个 U 盘下去，刚才工作人员拿了一个 U 盘下去，最上面的这个，上面最上面，对，最上面的这个。好，我们看一下啊，这是一个视频的一个展示。
Okay, this is a video. We use minimum invasive surgery for the bilateral cyst. During the procedure, we use this technique to spot the lesion, the cortex, and good suture, avoiding impairment to the cortex. This technique is very mature in China. This is a minimally invasive surgery, and to hide the incision so as to make it cosmetically good. And for the endometriosis, we also take the laparoscopic, the bilateral ovary cysts are found in two sides of the ovary. 6 centimeters of the lesion. This patient is infertile for years. We have used a single hole laparoscopic surgery. We have used a protection for the camera, avoid the spilling out of the liquids. So to provide a favorable environment for secondary treatment. And we have also conducted some treatment on the adhesion to restore it to the original cavity appearance. And we slightly suck in the liquids and the blood and to fulfill the surgery. We suck in all these liquids spilled out, and we found that the ovary is restored to its normal function. This is a very major concern for the gynecological department and the reproductive department. We should guarantee that the safety for the surgery, because all these ovary and the tubes are fragile. The recurrence of the endometriosis is very high, so we should combine it with the medication. Surgery impair ovary. Secondary surgery will impair the ovarian reserve, leading to the premature of the ovary. According to the international guidelines, the following medication will reduce the recurrence of the disease. All these medications, including the contraceptive pills, progestin, CPA, GH, and all these medications should be individualized for patients with different requirements or needs. Each medication has certain degree of limitation, and we can see that the post-operative GnRH can delay the recurrence of the operation. And according to the international guidelines, the Dinogest is a very popular medication. I have attended some international conferences. Some of the doctors will choose to conduct the Dinogest medication for the patients so as to protect the fertility of the patients without surgery. For those patients choosing the Dinogest, it will reduce the pain and control the growth of the cyst, avoid the secondary surgery. Dinogest will increase the live birth rate compared with the GnRH without impairing the ovarian reserve. So in conclusion, the ovarian endometrioma cyst impair the ovarian function and the fertility. So in treatment of the cyst, we should protect the fertility of the patients, using medication to control the disease, reduce the recurrence of the surgery, protect fertility, and provide a whole procedure management over medication, reducing the recurrence. A good medication will not reduce the ovarian reserve, and after discontinuing of the medication, the efficacy can be maintained for a long time. So that is very good or beneficial for the patients with fertility requirements. So that's all for my sharing. Thank you.